I am very happy to introduce our speaker for today. We have with us Katie Hauck, and Katie is a registered physiotherapist who specializes in pelvic floor physiotherapy with a special interest in the impact of cancer treatment on pelvic health. She is fortunate to work alongside exceptional therapists at Toronto Physiotherapy and talks frequently on how common cancer treatments can impact one's bladder, bowel, and sexual health. Katie is also passionate about sharing her knowledge and delving into traditionally uncomfortable yet significant health topics. So Katie, I will pass it over to you for our presentation.
Great, thanks for the introduction and thanks for having me today. I'm excited to be here talking about, there's my dog. Excited to be here talking about my favorite part of anatomy, the pelvis. Pelvis is a bit of a mystery area of the body. There's a lot going on in a very small space. So today we get to delve into the traditionally more taboo topics of how to manage bladder, bowel, and sexual health concerns following cancer treatment. So there is a bit of a question and answer period at the end. If we don't get to your questions today, I'm happy to leave my email at the end as well and answer any other questions that you may have. As I mentioned, with the pelvis, our pelvic floor, which are the muscles, they play many roles and many very important roles in the body. So following cancer treatment, there are some changes that you may notice, and that can be with the bladder, bowel, or sexual function wise. So hopefully by the end of the hour today, we can touch on some of these common concerns that you might be experiencing and really delve into some physiotherapy types of tips or exercises for really living well following treatment. Well, bladder, that's going to be if you find yourself going to the washroom more often than you were before, getting that strong urge to pee, or any problems controlling the bladder. Same with bowel, any problems controlling bowel movements, and any difficulty with sexual activity since cancer treatment. So starting out with a bit of anatomy. So on the right-hand side, you can see sort of a cross-section of the pelvis. So this would be if we drew a line straight down the middle of the body and split it up into left side and right side. So at the front, you see something called your pubic bone. At the back, that's our tailbone or coccyx. And connecting between those two bony points, we have the pelvic floor muscles. So you can see going through the pelvic floor, we do have your bowel or your rectal opening, and we do have the urethra or the bladder opening going through that pelvic floor. So right up next to that pubic bone, we have the bladder. This is the 5th most common cancer out of any cancer that we do see. About 45% of new cancers are actually found in the pelvis. And when it comes to bladder cancer, it's 3 times more common in men than it is in women. So that's something where the treatment for bladder cancer, we can see some side effects impacting that pelvic floor. Right below the bladder, we have the prostate. From a physio perspective, that's probably the most common one that we see some of those side effects with, especially the bladder. As you can see, our urethra or bladder opening, it's coming from the bladder and it does go through the prostate before we have the pelvic floor. So with types of treatments for the prostate, we can see changes on how well we're controlling the bladder. And behind that, we do have the rectum. So colorectal cancer is about 13% of new cancer cases. And sometimes we can see some side effects from that, particularly with controlling bowel movements. The other 2 cancers that we see in the pelvis are with the penis and testicles. from a physio perspective, it's not a common one that we're seeing effects on that pelvic floor. As you can gather, likely so far, when it comes to the pelvic floor muscles and the roles that it plays in the bladder, bowel, and sexual function, it's not so much the cancer itself, but the side effects from treatment for cancer that we're seeing on that pelvic floor. So next couple slides, we can delve into the surgery effects, radiation, and chemotherapy. So surgery for cancers in the pelvis, this might be removing just the cancerous tissue or removing the whole organ that the cancer is found in. Most common surgery that we are seeing from that physio side is a radical prostatectomy, and that's removal of the prostate and something called seminal vesicles. So if you look over onto the picture, that's that little worm-like structure going into the prostate. With the prostate, we do have a couple check control points as well. There's one of those control points that does get removed with the prostate as well. So sometimes symptoms we can see after this type of surgery is going to be challenges controlling the bladder. Clemacturia is another symptom we can see, and that's urine leaks with ejaculation. This happens in almost about half of individuals that have had this particular type of surgery. Cool thing to note with that one is there's some great research showing that pelvic floor muscle training can significantly decrease problems with bladder control. Erectile dysfunction is another side effect that we may see following a radical prostatectomy. With this type of surgery, we can get damage to the nerves that direct blood flow to the penis. And that's another consideration to look out for. Dry orgasms is no semen or ejaculate with orgasm. Sperm is produced in the testes, but the fluid is from the prostate and that seminal vesicle, which have both been removed. This is something that we can't really change with physiotherapy type treatment. It's just something to keep note of. And last but not least, constipation and bowel dysfunction. Anytime we have surgery through the abdomen, constipation is something to consider. So as surgery incisions heal, they heal by scarring. With our bowel, we have something called peristalsis, and that's the contractions of the bowel that move waste out of the system. If scars are slowing that down in any way, constipation is a side effect that you might notice. Now, the other common surgery that we're seeing from a physio exercise perspective is radical cystectomy. That's removal of the bladder, part of the ureters. So ureters are the piece that carries urine from the kidneys down to the bladder. Lymph nodes can get removed as well. And just like the prostatectomy, it also includes removal of the prostate and seminal vesicles. With a big part of our urinary system gone, we do need to find a way to take urine out of the body. So there's a couple of different options. Ileoconduit is probably the most common one, and also seems to have the lowest risks for side effects after. And this is where the ureters are attached to part of our small intestine. And that's then attached to an opening in the abdominal wall and then the bag is attached on the outside of the body to collect urine. Cutaneous reservoir is where the ureters are attached to a pouch that's made out of part of the intestine, and then that is attached to an opening in the abdominal wall. So catheterization is used to empty in this case. And last but not least, neobladder is the other option that you might see. And that's where a new bladder is made from the intestine. In this case, the bladder is about the same volume as a regular bladder, but since it's made from intestine, the sensation is going to be different. So it's going to function a little bit differently than a regular bladder. Because of that, we can see challenges with bladder control and challenges being able to fully empty the bladder. So sometimes we can get urine that stays left behind. If that happens often, being more prone to urinary tract infections is another symptom that you can see. Other than that, with surgeries as well and disruption to nerves, erectile dysfunction is something else to consider. And as we mentioned before, any type of abdominal surgery, we're considering the impact on constipation as well. Well, radiation effects. There's been great changes and advancement in technology for radiation, which has led to better local control of the treatment. What this means is there's better success rates, but now there's more of us trying to manage the side effects from radiation treatment. Basically, radiation causes fibrosis or scarring to any tissue that's in that radiation field. So that does include the arteries. In particular, the arteries that are responsible for blood flow to the penis, so starting an erection. When these ones are impacted, we can see some changes with erection function. Bowel dysfunction is something else we can see as well, particularly with scarring in the rectum or the muscles that are merging into the rectum. There does seem to be a dose effect with the radiation, where they're showing more radiation seems to have more challenges with erection function. So this ends up being least common with something called brachytherapy. And this is where radioactive seeds are planted in the prostate close to the cancer cells. So since there's less radiation, less tissue in contact with that radiation, there does seem to be less side effects following. The prevalence of challenges with erectile function, depending on the research you're looking at, it's anywhere from 10% to 60% of individuals that are going through radiation treatment for the prostate. This is a very similar rate to the radical prostatectomy or the surgery option. The main difference that you might notice is with the surgery option, the effects on erectile function tend to be immediate. Versus with radiation, we might not notice the effects until years later, so 3 or 5 years after treatment has stopped. Chemotherapy effects. So interesting to note that chemotherapy, it is going to slow down the production of testosterone. So that's going to have an impact on sexual desire and erections. This is something that's temporary and resolves within 1 to 2 weeks of finishing treatment. Usually chemotherapy is going to affect what we call our distal peripheral nerves. So those tend to be the nerves in hands and feet. But if the pelvic nerves are impacted as well, nerves are what control erection and ejaculation. So that may be something that you do notice. On a positive side, anytime that we do have some nerve signals going through, there's always the potential to change and see improvement. So delving back into common concerns you might notice. So starting out with the bladder. Our two more common bladder changes that we see following the surgery route or the radical prostatectomy. There are different types of bladder leaks or incontinence. Stress urinary incontinence is typically the leaks that you get with coughing, sneezing, jumping, laughing, anything that's going to add that pressure onto the bladder. And clematuria, as a reminder, that was urine leaks with ejaculation. So these type of leaks are typically go along with weakness or lack of control of the muscles. With our bladder, we have a couple different checkpoints or a couple different control points. On that right-hand side, you can see the bladder up top as a circle. There's that prostate and then the penis. So the urethra is going from the prostate all the way down to the outside. There are a couple arrows pointing at a couple different muscles. So we have two checkpoints on the inside. These are ones that we don't have control over. We can't consciously think of these muscles and be able to use these muscles. They do that work on their own. We only have one check system that we can control, and those are the muscles in the pelvic floor. So this is our very last checkpoint when we want to stop or pee or control the bladder. With the radical prostatectomy, one of those internal checkpoints is removed. So instead of having 3 spots that we can rely on to control our bladder, we're now left with 2. This means our pelvic floor has to be extra good or extra impressive at being able to control the bladder. Challenges controlling the bladder is very common after the surgery, so up to 87% of individuals. On the positive side, after only 3 months of pelvic floor muscle training, a huge number, 88%, were able to achieve full control of the bladder. Clematuria, as I mentioned before, about half of individuals can struggle with this type of leak. And even with that one, there are significant improvements with controlling the bladder from pelvic floor muscle training. The big challenge with training these muscles, as we can delve into a little bit later, is most of the muscles are on the inside of the body. But they can be hard for our brain to connect to, particularly after something like surgery. Well, if you are following up with a pelvic floor physiotherapist, a bladder diary is something that they might recommend doing following surgery to see how is your bladder reacting. So as you can see, this would be an example of someone that is going quite often throughout the day and having quite a few leaks throughout the day. Our other type of bladder control that we can see is called urge incontinence. So this is that strong urge that you have to go to the washroom, you're rushing there and don't quite make it in time. On the less extreme side, other symptoms such as that strong urge to pee, going often throughout the day, or getting up at night to pee can be other symptoms as well. These are all typically symptoms of not necessarily weakness in the pelvic floor, but tension in the pelvic floor muscles. Our pelvic floor and bladder, they do communicate and talk to each other. And they also communicate with the brain. On the bottom left-hand side, you can see we have a normal full bladder. And at the bottom there, those are the pelvic floor muscles controlling the bladder. So if we don't want to pee, they're the ones that are going to contract and close off that urethra so we can hold our urine in. As our bladder fills up, it will start to stretch. When it stretches, it sends a signal up to our brain. If our brain knows the bladder is not full, that's that arrow going down, it signals the pelvic floor. Our pelvic floor contracts, and that tells our bladder to relax so it can keep filling up to its full capacity. Where things can become a challenge, if there's tension in that pelvic floor muscles, we lose a signal to the bladder telling it to relax. That might mean we only have a little bit of urine in the bladder, but it's going to feel like you have to go and you have to go now. Tense pelvic floor also doesn't work great at creating a good closure around that bladder opening. And that's where we can see those urge leaks happening. Options or strategies for the bladder. There's a couple different areas that we can look at. So looking into diet and our routine, particularly with a neobladder, looking at time toileting or coming up with a schedule of when to use the washroom can be a strategy. And then exercises as well. In some cases, that's going to be more of a strengthening exercise for the pelvic floor. In other cases, it's releasing that tension in the pelvic floor. When it comes to diet, even small changes can be a helpful tool just to offload the stress on the bladder. There are common things that can be a bit more bladder irritants. So it's something to keep in mind if you can keep track of something that you've ate or something that you drank where you felt that strong urge to pee after. These can be good things to look into. Some common culprits that we often look at can be things like coffee, alcohol, and carbonated drinks like Coke are all ones to just keep in mind. As I mentioned with the neobladder, coming up with a schedule of when to use the washroom to make sure that you're fully emptying the bladder and not having urine stay around too long. If you're getting that strong urge to pee, that's creating that urge incontinence, there's a couple of different strategies that a physio might discuss with you, like self-talk, slow, deep breathing, or focusing on releasing, relaxing that pelvic floor, or sometimes even contracting the pelvic floor. So as I mentioned, coffee and alcohol can be common triggers for that bladder. Exercises, strengthening of the pelvic floor. I mentioned earlier, the pelvic floor can be tricky to retrain again. A big part of this is there are a lot of muscles that are working together in the pelvic floor. Majority of these muscles are on the inside of the body. So we can't see them. They're also hard to feel. It's a challenge to know what muscle are we getting. Very different than if I asked you to come up with an exercise to train your bicep. You can see your bicep, you can feel it. You know that when you bend your elbow, you're gonna work out that muscle. The best way to train a muscle is to be able to feel it and know what the muscles are doing. The gold standard for training pelvic floor muscles is through a hands-on exam with a pelvic floor physiotherapist. And that's where they do an internal rectal exam where they're able to feel the muscles when you're doing a strength exercise to know exactly what the muscles are doing and help provide some good feedback for training. With the pelvic floor, we tend to divide it up into two parts. So right now we're looking at the bottom. So top, we have the penis. You can see the rectal opening, the tailbone at the very back. And on the sides, we have the two sits bones, which are the bony parts in the butt. If we combine all that together, we have a diamond shape. When we split the diamond in half, we have a front triangle and a back triangle. The front triangle includes the urethra, is more focused on bladder control, versus the back triangle that has the anal opening is going to be more focused on controlling bowel movements. When it comes to stress urinary incontinence or clemacteria, we want to focus on that front triangle or the one that's going to control the bladder. All the muscles are going to work together as a team. When you're doing your Kegel, it's finding a cue that works for you to draw the focus and attention to that front triangle. Ones that have worked well in the past are thinking of shortening your penis or drawing your penis in, turtle pulling back into its shell, pulling a train back into the station, or my favorite one, you just walked into a cold lake type of feeling. They're all ways to draw our attention to that front triangle. Well, if it's tension, whether it's from radiation fibrosis, from some of the surgery scars, or just protective mechanism of the muscle, releasing that tension is the exercises that are going to be most helpful for you. That might include some hands-on type of treatments to release tender points in particular muscles or tightness in connective tissue. From an exercise perspective, instead of a strengthening exercise like a Kegel, we're doing the opposite, called a reverse Kegel. With the reverse Kegel, we need to know about another important muscle in the body, which is the diaphragm, or our breathing muscle. So that's the muscle sitting at the bottom of the rib cage. If you're taking a deep breath in, placing your hands just kind of at the bottom of the rib cage, you're looking to feel the hand moving there. The reason this works really well at releasing tension in the pelvic floor is the diaphragm and the pelvic floor muscles work together, almost like a piston. On the right-hand side, you can see we have the diaphragm up top, pelvic floor at the bottom. When we take a deep breath in, the diaphragm actually moves down. This creates pressure in the abdomen, so that pelvic floor below also moves down and releases tension. As we breathe out, they naturally come back in. A trick to try out later at home, if you want to see, are you using your diaphragm or are other muscles taking over, is to place one hand on your chest, one hand at the bottom of the rib cage where the diaphragm is. When you take a deep breath in, what hand do you feel moving first? If your top hand is the one moving, you're probably a shoulder breather, using other muscles in the neck and chest to do the work for you. Versus if it's the bottom hand moving, you're more of a diaphragm breather. A diaphragm breath is the one we're looking for to have that change and impact on the pelvic floor. So moving on to bowel. So are you having challenges fully controlling bowel movements? Well, constipation, as we mentioned, can be a common side effect of cancer treatment. That's typically from the impact on peristalsis, so movement of waste through our large intestine out of the body. And that can be from scars when we go through the abdomen for surgery. Fibrosis from radiation treatment, can also impact how quickly the waste moves through the system. Anything that slows down that transit time can create struggles with constipation. Fecal incontinence or challenges controlling bowel movements can be very common following rectal surgery. A reason for this is that the rectum starts to merge with some of those pelvic floor muscle fibers. So our pelvic floor or our checkpoint tends to get weakened in the surgery. On the plus side with this one as well, there's great research showing that a supervised pelvic floor exercise program can have significant improvement on being able to control the bowel. Some strategies for the bowel. Fiber tends to be one of our top strategies. If you're finding that the stool is looser with some changes. On the right-hand side, we have something called a Bristol stool chart, which just basically gives us an indication of, are we having sort of the normal bowel movements that we're looking for, so more that sausage type shape, or are we on the more constipation side, or on the looser side or diarrhea side, which can be a sign that we're lacking fiber. Our bowels also respond really well to habit or routine, and that can be something else to consider as well if you're noticing that your stool is looking a little bit off following treatments. From the more physio side, some of the great strategies are positioning as well as looking into exercises, and external supports can help as well. So positioning, particularly with challenges with constipation, we have one muscle in our pelvic floor that creates kind of a sling around the rectum. This is an important muscle to have working as it's going to control the bowel. So it creates one of those checkpoints. If there is too much tension in that muscle though, our bowel movement now has to work over this big kink to be able to leave the body. As you probably noticed, most toilets or most seats that we're sitting on, it's very rare that our hips drop below the level of the knees. When our hips are above the knees, there's going to be a lot more tension in this particular muscle in the pelvic floor. So squatting, or positions that get the knees above the hips, as you can see on the right-hand side picture, straightens out that rectal canal, relaxes that muscle in the pelvic floor, and basically just creates a smooth channel for waste to leave the body. Squatty Potty is something that you might consider investing in if you're struggling with challenges of constipation. Or on the cheaper side, a dollar store stool is also a way to get into that position of the knees above the hips. Strengthening the pelvic floor. Before we talked about the front triangle, in this case, we're now looking for cues that draw our attention to the back triangle. Visuals that work well for this one, as bizarre as it sounds, is picturing a marble sitting at the rectal opening, trying to draw a marble inside, or a stop a fart feeling. Whether you're training the muscles in the front triangle or back triangle, if you're trying it out later at home, see, can you hold that muscle for 10 seconds? After the 10 seconds, can you fully let the muscles go? Working on training the muscles faster as well. So very quick, 2-second on, 2-second off is another great training strategy. With either one that you're practicing, when you do it, do you notice you're lifting up off the chair, or are the abs crunching in? This might be a sign that other muscles in your body are trying to take over and do the work for the pelvic floor. As a temporary solution or strategy that we can add, there's also something called a renew insert, which is just a little device that you can insert into the rectum as an alternative to using incontinence pads for bowel control. This is a great solution to do alongside the muscle training or the strengthening program. Last but not least, sexual function. So any difficulties with sexual activity since cancer treatment. In particular, we tend to see challenges with erectile function. With the research, this can be anywhere from 60 to 90% of men following radical prostatectomy, the surgery route, or about 67 to 85% of men following the radiation therapy route. So with erection, we do have 2 phases or 2 stages. So vascular phase is the blood flow. So that's what starts erection. A lot of strategies like Viagra and Cialis, these are all targeting that vascular phase. The second phase, or the muscular phase, is our often more forgotten phase. And this is what keeps the erection or provides a rigid erection. So this is where the physio focus or muscle training focus tends to be. Rigidity is created by contracting a particular muscle in the pelvic floor called your ischiocavernous muscle. So this is a muscle on the outside going from your sits bone, that bony part in the butt, wrapping around the base of the penis. When this muscle contracts, it's what puts pressure on the channels in the penis and keeps the blood in the area. And in the picture below, that's the highlighted red muscle you can see on each side. Research has shown that after even 3 months of pelvic floor training, in particular trying to target this specific muscle, has had a positive impact on erection function. When it comes to treatment, there seems to be lack of consensus on what is the ideal regimen. Everyone seems to agree that the sooner you can start, the better the outcome. So the more erections now, the better odds of having future erections. A lot of the medical interventions, like we mentioned, that's targeting the vascular phase, so the blood flow piece. And that might include low-dose PDE5 inhibitor. So that's the fancy name for Viagra or Cialis or any of those types of drugs. Vacuum erectile device or injections into the penis. Well, we're focusing, as I mentioned, more on muscles, and that's that muscular phase. Hands-on treatment may be something to consider if there's overactivity in those particular muscles or tightness in connective tissue that can impede blood flow to the penis and can have an impact on ability to achieve an erection, or can impact on how well you can contract those muscles that keep the erection. Otherwise, the exercises are focusing on strengthening that ischiocavernous muscle, or that muscle that was going into the base of the penis. And physical activity is something to consider. as well. So strengthening, as you mentioned, 3 months of a guided pelvic floor therapy program working on training the muscles has shown to have positive effect. The way to target this muscle, any muscle that we're looking to strengthen, we want to contract along the muscle. So if we're strengthening our bicep, we want to make sure we're bending our elbow or bringing our elbow to our shoulder. With this one, it's picturing more of an X or cross movement. If you're wanting to try this one at home, a couple tips and strategies are sitting in a chair. If you wiggle side to side, you can feel that bony part in the butt. That's the sits bone. If you sit on your hand and put the fingers just on the inside of that sits bone, you're going to be on top of that muscle that we're looking for. From there, picturing drawing the sits bone on one side, up across and in towards the opposite pubic bone on the front of the pelvis. If you've got this one right and you have your hand on the outside, you'll feel that muscle kind of tighten under your fingers and relax as you let go. If you're a visual person, other tips and tricks that we recommend is using a mirror to be able to see what those muscles are doing. Now, with all the great research coming out around physical activity and exercise, it's something that we can't forget to mention. Not only does exercise reduce the risk of cancer recurrence and mortality, it's also associated with lower risk of erectile dysfunction. And on the opposite side, obesity is associated with a higher risk of erectile dysfunction. The general guidelines for physical activity is about 150 minutes per week of moderate to vigorous intensity. And there was shown to have added benefits of strengthening 2 times per week as well. Whatever cardio option you decide to do for your 150 minutes, as long as it's something that you enjoy and works well in your routine, they didn't show any benefit from one type of exercise over the other. Okay. And just want to highlight, while strengthening can have a lot of positive results, there are times when it might not be appropriate to strengthen. If you just had surgery, it's recommended to wait at least 6 to 8 weeks just to allow that natural healing in the body. If you have a catheter in place, we don't recommend Kegling around the catheter, as that can cause retention of urine and more risk of urinary tract infections. Last but not least, pain tends to be the sign in our body that there's tension in an area. And the exercises that may have more of a positive effect were the ones that were releasing and lengthening tension rather than strengthening. Well, if you're looking for a pelvic floor physio in your area or more information, Pelvic Health Solutions is a great resource. They list, particularly for Ontario, most of the Ontario physiotherapists by area. They do cover a few other provinces in Canada and a couple international, but it definitely does not list everyone. And you're welcome to check out our website as well if you are looking for more information. We tend to post research reviews often. And at any point, if you do have questions that we don't get to today, please feel free to reach out. I'm happy to answer your questions at any time.
Thank you so much, Katie, for that presentation.